me to many people in this room, but and there's a lot of action that goes on here. And the podocyte is central to glomerular filtration, and it's this area right here in this slit diaphragm, and these key genes, Neph1, nephrin, actinin, alpha, and TRPCA that are very important. And you'll hear more and more about this afternoon by some of the other speakers. So as I was trying to think about this talk, I thought, well, let me go back a little bit and just look at the history of nephrotic syndrome. And I don't think I've really ever done that. And so Hippocrates, many years ago, talked about generalized edema and called it dropsy, and that's how it was originally thought about. And then it took quite some time until 1722 when Zinger noted that there was decreased urine output and attributed this to the obstruction and compression of tubules of the kidney. And then nearly 200 years later, Richard Bright described the anasarca proteinuria and kidney disease that we know as nephrotic syndrome. And further work by colleagues of him noted that protein was highest in the urine when it was lowest in the blood. So in 1830, nephrotic syndrome, the diagnosis was coined, and people were continuing to work. And initially, Virchow was saying that he called this parenchymatous nephritis, and that it was didn't distinguish very much between glomerulonephritis and nephrosis. And so in 1872, one of his colleagues, Klebb, differentiated between nephritis and nephrosis. But then it was not until Mueller in 1905 that differentiated those completely. So it took us a while before we got separating the glomerular diseases and the nephrotic condition. So also, going back in the 1950s and 60s, we only had light microscopy. And so from there, we were learning about membranous and other proliferative conditions, diabetic nephropathy, and FSGS. And so this is the spectrum of nephrotic syndrome that we all know, and it leads to hypoalbuminemia, edemia, hyperlipidemia, and lipiduria. And when we think of nephrotic syndrome, we think about it in many different ways. We think about it in the context of age, whether it's the pediatric population or the adult population. We think about it as far as histology, minimal change, membranous, or FSGS. We think about it in the context, is it primary or secondary? And then we also think about nephrotic syndrome in the context of how it responds to therapy. Is it steroid sensitive, steroid resistant? And so I'm going to spend just a couple slides on infantile nephrotic syndrome. Many of our adults have never seen this. We don't see it very, very often. It is clearly where genetics comes into play. We see there's autosomal recessive forms, with nephrin being primarily that condition that causes nephrotic syndrome in those patients under 3 months of age, and then WT1, Podocin, and some of these other ones are more likely to occur in those children that are greater than a year to 2 years of age. So when we see a child come in with, or an infant or a small child with nephrotic syndrome come in, we're always going to do a genetic workup on this population. We also have some autosomal dominant forms that are also associated with nephrotic syndrome, and you'll hear more about the genetic mechanisms of nephrotic syndrome later by Rashid. That's just a duplicate slide. When we think about the presentations of primary nephrotic syndrome, this is a slide I borrowed from our NephCure colleagues. We see that there's minimal change, which on histology shows minimal to no visible glomerular changes, and 90% of those will have a therapeutic response. We then can also see focal segmental glomerulonephrosis, which shows more of the scarring in that glomerulus, and then membranous nephropathy, which we don't see much of, and we didn't used to see much of it in the pediatric population, is predominantly more of an adult disease. So let's talk a little bit about primary nephrotic syndrome in children. So the incidence is somewhere between 2 and 7 cases per 100,000 children. I feel like that's all we see day in and day out at our institute. These are our frequent flyers. They're in and out of the hospital all the time. The peak ages in that preschool child, 80% of the cases with their presentation occurs less than 6 years of age. There's a slight male predominance, African Americans greater than whites in North America, and some small familial component. This again is our podocyte. So this is a healthy glomerular basement membrane, and you can see when the podocytes maintain their integrity, albumin stays on the glomerular capillary side and does not leak and cause all the problems that we see in nephrotic syndrome. Mechanisms that have not been fully elucidated to date may have something to do with just the baseline integrity of the podocyte, but also soluble mediators, B cells, T cells, we think come to play to disrupt this glomerular basement membrane. We get effacement of these podocytes, thereby allowing disruption in the basement membrane and the albumin to leak into the blood space. Again, you're going to hear more and more about this later on by other speakers. If we look at the etiology nephrotic syndrome, in our world, supposedly 70 to 80% of children who present with nephrotic syndrome are going to present with minimal change disease. You can see that this is definitely age-related, starting at 1 year of age and later. We predominantly see minimal change. We see focal segmental across the whole age spectrum, but with respect to membranous, we see very little membranous in the pediatric world, but as patients age, membranous becomes a predominant cause of nephrotic syndrome. This is a nice cartoon that talks about the different forms of focal segmental glomerular sclerosis, which is the more aggressive form of nephrotic syndrome. There's primary nephrotic syndrome. There's APO1-associated nephrotic syndrome, which is predominantly seen more, or has a higher risk factor in our African American population. And we see adaptive focal segmental glomerular sclerosis, which is prematurity, obesity, solitary kidneys. These three seem to have an equal amount of prevalence. These other ones, the genetic forms of FSGS, viral-associated FSGS, HIV, and some of the other ones, are less described, and so the prevalence of them is less understood. We are involved with a collaborative with NephCure Accelerating Cures Institute, and currently, and this is sponsored through NKI and NephCure, and currently we have about 1,000 patients in this registry, 2/3 adult and 1/3 pediatrics. When we look at just the pediatric data alone, a little bit different, where we're expecting 70 to 80% of kids having minimal change and about 8% having focal segmental glomerular sclerosis. In this population, currently we have about a little over 1/3 of our patients with FSGS and only 50% with minimal change disease. So many of us have questioned whether dynamics are changing a little bit around the different etiologies of nephrotic syndrome in children. We'll talk about it in a minute, but many years ago there were some studies done that we used to biopsy all children with nephrotic syndrome at presentation. Because we think 70 to 80% of those now have minimal change, we don't do that as much as we used to. Indicators for us to do a biopsy in a pediatric population is either that under one group or even often 2 years of age, and that preteen or that adolescent population. If they have a constellation of gross hematuria, hypocomplementemia, marked hypertension at presentation, renal failure, or any other positive signs that would make us think of some secondary cause such as lupus, or if they've developed steroid resistant or on the need for calcineurin inhibitors. So if you go back historically and look at ways that people used to treat nephrotic syndrome, there's many different things. Obviously, there's dietary modifications and low-salt diet, which nobody likes, particularly our teenage kids, when you tell them they can have pizza and hot dogs and all those good things that teenagers and toddlers like. There have been times where people have used mercurial diuretics. There were times where, because we think there's a T-cell component to nephrotic syndrome in children, we would induce measles or vaccinia to see whether or not they would go into remission, and many of those would. There have been times when people have looked at blood cell transfusions, thyroid extracts, decapsulization of the kidney, all kinds of different things, which really did not have much effect on the long-term benefit of the disease going into remission. I wanted to put on here antibiotics because we saw that once they came into place, particularly penicillins, that mortality reduced from 67% to 35%. So that was a real game changer for us in the pediatric world. Many of these children can present with overwhelming infections, and so antibiotics have been a godsend. The next thing that came into play were steroids, which were not isolated and identified until 1936. And then we went through cortisone, we went through ACTH, and then prednisone became the mainstay in the 1950s. Again, between antibiotics and the presentation or the initiation of prednisone therapy, the mortality in our population has drastically decreased, as well as in the adult world. So if you look back at key things throughout the treatment in kidney disease in general, antibiotics and steroids have been huge. So ISKDC is the International Study of Kidney Diseases in Children, and in the era after renal biopsies, where we found that the majority of these children had nephrotic syndrome, and all kids in this study had to have a biopsy, and the introduction of steroids, the ISKDC was established to try to better understand the management of childhood nephrotic syndrome with participants from North America, Europe, and Asia. Interestingly, as some of us have gone back and looked at this, There's no information on demographics. We don't know what the racial and distribution was in this population as we do now, where it's much more selective. So this organization did a series of prospective, multi-center collaborative studies to help establish definitions, steroid-resistant, frequent relapsers, all those types of things, the clinico-pathological correlations, and recommendations for therapy. We'll talk about a few of those. So this study went from 1967 to 1974. There were several publications that came out of this. They had 521 pediatric patients. In order to go into this study, all patients had to have kidney biopsies, and much of what we do now is based on these original studies. And you can see, again, that about 80% of the kids have minimal change disease, and hence why we don't biopsy every young patient that presents with kidney disease now. It was their recommendation, and based on these studies, that we would do prednisone, 60 milligrams per 24 hours per meter square with a maximum of 80 that would be divided daily over 4 weeks. And then after 4 weeks, they would go into an every other day therapy. So that stayed my entire training. This went into play. And back in the 80s, some European studies showed that maybe a 12-week course, kind of mimicking what they've done in the adult population, which is even a longer course, showed better response and less frequent relapses in this population. So back in the late 80s to early 90s, we went from 8 weeks of steroid therapy to 12 weeks of steroid therapy. You can see that this is the time to response to prednisone, and it's much quicker in the pediatric population as opposed to the adult population. By and far, 50% of pediatric patients are going to respond to steroids within about 8 days. And by 4 weeks, probably 80 to 90% of children have responded to prednisone therapy if they're going to be steroid sensitive. Clearly, the adults aren't quite so fortunate, and sometimes they take much longer, 2 to 3 months, to go into remission. So their course of steroid therapy is going to be much longer than ours. So steroid sensitivity is probably by and far the greatest predictor of how people are going to do with nephrotic syndrome, whether you are a pediatric patient or whether you're an adult patient. So if you look at those that initially have steroid responsiveness, about 80% will show initial steroid sensitivity. 60% will then go on and develop a frequent relapsing course or a steroid-dependent course. And then less, thank goodness, have a late steroid resistant. We'll see certainly that some of these kids will start out here, then they march into here, and then they go into here and require further therapies. So in our population, as well as the adult population, nobody likes steroids. Parents don't like steroids. Toddlers don't like steroids. Adolescents really don't like steroids. I don't think anybody likes steroids, actually. And so when we are having to repeatedly put them on steroid courses, we get into what agents can we use from a steroid-sparing option. I think the take-home message of all of this, these can all be effective, but they don't treat anything. They kind of ameliorate, they keep it at bay, but they don't necessarily treat it. So when I first started training, we had azathioprine. Really has not been a great thing in nephrotic syndrome. There's really no difference between it and placebo and control. And then we go into the alkylating agents. When I was trained, if you came from Northeast, you used a lot of chlorambucil and nitrogen mustard. If you were from the South, you were in the Cytoxan world. I don't know if everybody else, I've never seen chlorambucil used. So these are great agents, particularly for those children who have steroid dependence, frequent relapsing. It allows you an opportunity to give them a medication over an 8-week period of time that maybe will lessen their frequent relapses and give them some time off of steroids. Although these agents aren't very good, and when you talk to parents about the fertility issues of their children, they often are like, I think I might want to stay away from that one. I personally have seen many of these kids go on and have plenty of children, and so we give them only 8 weeks of this therapy. But you may not want to use that therapy for multiple reasons. And then levamisole is another agent that's particularly good in frequent relapsing nephrotic syndrome. We just can't find it here in the States anymore. This is actually an antihelminthic, and it seems kind of odd that you would treat worms in nephrotic syndrome the same. But when used, is very effective, and in European countries, they like this medicine a lot. Then our other agents, we have the calcineurin inhibitor option, which is cyclosporin and tacrolimus. And many studies have looked at cyclosporin in the use of nephrotic syndrome. There have never been any back-to-back studies between cyclosporin and tacrolimus, and there probably aren't going to be any. And these agents are good in our steroid-dependent group. Mycophenolate mofetil is another agent that many parents will choose it over our alkylating agents because they think the toxicities are much less, and it seems to be more tolerable. Once you put them on this, though, you're committing them to this for a while. And so unlike this, an alkylating agents, which we will use for an 8-week course or 56 doses, mycophenolate, they're going to go on it and they're going to stay on it for a while. And there's GI complications that can be associated. And of course, with any of these drugs, some of them have these big black box warnings, and so the parents always love talking about leukoencephalopathy and their young toddler that may go on MMF. I often tell them that we don't see it, and I've only know of one person who ever has, but it's a little intimidating for the families. And then rituximab is probably our latest agent that has come into play in our steroid-sensitive, steroid-dependent, and often there are some patients with steroid-resistant nephrotic syndrome from FSGS who still, for reasons that aren't well understood at this point, they respond well to rituximab. Again, I think no matter which of these agents we use, we're just trading off in toxicities and we're trading off in dependence. So many of the kids I have that I can get off steroids and many of these other medications are very responsive to rituximab, but in 6 months they relapse again, or in 3 months they relapse again, or in 1 year they relapse again. And so you're continuing to have them be dependent on some medication. It's just which one, you pick your poison. And so we need better therapies. Maybe Dr. Gibson can tell us what's in the newest and best in medications. This is just kind of a historic, back in the 80s and in the 2000 and 2007, rituximab seems to be our hot new agent at the moment. In our steroid-resistant forms, many much the same medications. KDIGO guidelines of 2012 recommend that a calcineurin inhibitor would be at the top of the list of agents to use. Other agents, MMF, some people are responsive to that. There's a nice abatacept study that's sponsored from Bristol-Myers Squibb that we're currently enrolling patients in. I need to go see one in a minute who's here to get her infusion. ACTH Actar, there's studies out there on that. And then anti-TNF agents are being utilized in some areas. Remember that in this group particularly, and in our world, 30% of these patients will have a genetic mutation, which may alter also what we choose to do. When you look at outcomes for nephrotic syndrome in the pediatric population, many of these kids will be relapse-free for about 18 to 24 months. I would like to see a lot of these kids because I don't get to see them very often. The nurses here on the 8th floor, they don't either because they are our frequent flyers. About 20 to 30% will have infrequent relapses, and 40 to 50% of these kids will either have a frequently relapsing course or a steroid-dependent course. As I mentioned earlier, most of our outcomes, the main morbidity derives from all the side effects of the medications that we use. These kids are primarily immunosuppressed from the medicines that we use. They can have impaired linear growth, particularly when they're on prolonged steroid courses. They can get thyroid dysfunction just from loss of thyroid binding globulin. It's really unknown about the long-term toxicity of many of these agents. I think gonadal toxicity we feel pretty good about with respect from the chemotherapy world, the oncology world, and having followed enough of these kids through the years to give the families a good idea about that gonadal toxicity. Many of the agents that we use are toxic to the kidneys. Calcineurin inhibitors, we're trading off, we're maintaining their disease, but they're scarring as a result of being on a calcineurin inhibitor. Steroids and diabetes, hypertension, osteoporosis, truncal obesity, and then solid or bone neoplasias. We don't know what being on these medications for years and years that many of these kids are on these medicines from the time they're 2 up until their adult years when they get put on further immunosuppressive therapy. So these are some areas that we don't know much about. And then long-term studies of childhood onset minimal change disease, particularly of those kids that are followed into adulthood. About 3% of them will show some development of chronic kidney disease, and once they hit the adult world, 16 to 42% of them will have recurrent disease. So our adult colleagues, we just pass them on to you guys, unfortunately. So I thought I'd spend a few minutes just talking about some of the complications that many people probably don't think about with nephrotic syndrome. And so those are infection, thromboembolism, and acute kidney injury. Infection is often due to impaired humoral response. They have reduced serum immunoglobulins. If we're to measure IgG in many of these kids who have chronic refractory disease, they're often hypogammaglobulinemic. They have decreased factors, factor B and factor D, which help them deal with opsonization of encapsulated organisms. They have impaired T cell function, and they've been on long-term immunosuppressive therapy. Like I said earlier, prior to 1940, the mortality rate was 40% in the population that we deal with, mostly due to overwhelming sepsis. So things we worry about in our world are acute peritonitis from strep pneumo as well as E. coli, pneumovax and Prevnar that continues to expand in the serotypes that it affects have certainly lessened. I used to see a fair amount of peritonitis when I was in training. We kind of went through a period where we didn't see much. Just because they're immunized against these things, they still get peritonitis, and we see that with some degree of frequency still. They can get cellulitis. They've got stasis in their lower extremities from a lot of this fluid. So we've seen sepsis from E. coli and Klebsiella, meningitis, urinary tract infections. Chickenpox can be devastating to these kids who are on steroids. So Varivax has really been a lifesaver for that condition. So with respect to thromboembolism, it's the most serious complication of nephrotic syndrome. As early as 1840, renal vein thrombosis was the first thrombosis that was recognized to be associated with nephrotic syndrome. But with modern anticoagulation and thrombolytic agents, this has certainly decreased the risk of thromboembolism-related mortality. I think this is something that also is seen much more commonly in the adult population, but we certainly see it some in the pediatric world. This is just a little picture that kind of shows the constellations of things that can be all involved in thrombosis. There are those people who have a genetic background that puts them at an increased risk for thrombosis, regardless of whether they had nephrotic syndrome. That chronic inflammation that we see in these patients, some of the medications that they're on. Many of these patients will have a central venous catheter for one reason or another, and there's an imbalance between the procoagulant and the anticoagulant factors. Some are lost through the urine, the liver is jazzed up trying to make more, and so it sets up this nice milieu that makes it a great area for thrombosis. And this is just kind of showing that scale. It gets tipped out of balance to be more procoagulant than anticoagulant. If you look at thromboembolism, 25% of adults with nephrotic syndrome will have some thrombotic event, and only 3% in children. It does increase with advanced age. It's most prevalent in that early course of the disease within the first 3 to 6 months when their disease is so uncontrolled, and it varies with type of nephrotic syndrome. This is just a little indicator that in our world and the adult world as well, membranous is by and far the most common nephrotic form of nephrotic syndrome that will lead to thrombosis in about 37% of the adult world and a little less in the pediatric world. Vasculitis-associated nephrotic syndrome, and then our really small population, the congenital nephrotics, who we really have a very hard time getting controlled, and often leads to nephrectomies in that population just to get their nephrotic syndrome controlled. This is always an interesting group because you're taking a population that has totally normal GFR, and you're going to take their kidneys out and transplant them. But it's a life-saving event in their lives. If you look at, we see renal vein thrombosis, which can present with macroscopic hematuria, flank pain or tenderness, or acute kidney failure. Deep vein thrombosis, we've had a young man in recently that's had several issues with this. And then luckily we don't see CNS thrombosis very often, but it's also something that we worry about. I was going to spend just a second talking about acute kidney injury in the pediatric population. The majority of pediatric hospitalizations are complicated by some degree of acute kidney injury in the nephrotic population. It's much more commonly recognized and talked about in the adult world, but some recent studies are coming out that anywhere between 30 and 40% of kids who are admitted with a flare in their nephrotic syndrome will have some degree of acute kidney injury. Risk factors are intravascular volume depletion. Many of these kids also have underlying infections that either set off their relapse or they're a complication of their disease. They have exposure to nephrotoxic agents. Calcineurin inhibitors are often on ACE inhibitors. They're on diuretics, they're on antibiotics, they're on nonsteroidals, and you put all those in the context of an intravascular depleted state, and it's just a setup for acute kidney injury. And they get a lot of renal interstitial edema that leads to vascular congestion. Many of these kids will require transient or temporary acute dialysis to kind of get them through this process. It results in a longer length of stay, which none of us want, and certainly the insurance companies don't like that either, and we would like these kids to not be in a hospital and school where we want them to thrive. These kids are more likely to require an ICU care. The risk factor for development and progression of CKD seems to be associated with these bouts of acute kidney injury, and obviously our steroid-resistant nephrotics are at the highest risk for acute kidney injury because we never can get them into remission. So just a minute on therapeutic options. I thought I'd make this slide just to kind of go back to what we said a minute. So we started way back when with steroids. Then we kind of went to azathioprine. It fell out of favor. Then we've got levamisole. We can't get here in the States. Then we go to calcineurin inhibitors, which have their own degree of toxicity, but they work very well when they do. Then we jump down here to MMF now, and depending on where you are in the country, if you go to Atlanta, MMF is their big thing. If you go somewhere else, alkylating agents may be more popular. Now we're down here to rituximab, which many of us have found very, very effective. But again, none of these have resulted in a cure. We're just trading dependence. And so we're hoping one day we're going to get this one down here that's going to give us a cure to some degree of these kids with nephrotic syndrome in adults. Future directions. Dr. Gibson will talk a little bit more about this later, as well as some of the other speakers. ACTAR, some people are involved in a study that's going on looking at this as well. The mechanism is unknown. This has kind of been in and out of favor through the years. Other information, we're doing some high-risk variants with APOL1, and you'll hear Dr. Friedman talk about that later today, as well as Dr. Hippen. And then these are just some agents that may be promises on the horizon. And I'll leave these to some of the other speakers to discuss. That's all I've got. Thank you.